So OMIDRIA is beneficial to the patient because it gives the patient less pain after surgery, but also it allows the surgeon to have a widely dilated pupil throughout the entire steps of the cataract surgery, which benefits every single part of that so that the surgery goes smoothly. And then the facility benefits in that we've done studies, and there's multiple studies out there showing that we use less Malyugin rings or iris hooks on patients who have OMIDRIA. So that's a cost to the center. The actual hospital center or the ASC doesn't get reimbursed for those Malyugin rings, and they're costly. And then I think you can also show that it's less likely to have a complication with OMIDRIA. We've seen some studies with that, so less chance to pull out the vitrector, less chance for a longer case, maybe complications with vitreous into the anterior chamber or dislocated lenses. Again, if you can't see what you're doing because the pupil's too small, so that benefits the center as well. And then post-operatively, we've noticed in our study of using OMIDRIA intracamerally and just a topical NSAID like bromfenac, we reduced our CME rate from the typical 2 to 3% down to only 0.4%. And so this is a large population of patients, of all my cataract patients over a year, where we use no steroid. We just use 2 NSAIDs, if you will, 1 intracameral and 1 topical, and we have a poster here at ASCRS talking about that. And we've really reduced our CME rate. So that benefits my chair time with the patient, that improves my results, and then also less having to check OCTs or send patients to retina clinics or even doing like sub-Tenon's injections of Kenalog. I would worry that my surgical manipulation was going to make that pupil come down a little bit smaller. And once that happens, every step of the procedure gets a little more difficult, including the capsulorhexis and lens fragment removal. Sometimes these little fragments will hide behind that undilated iris, or even just the cortex removal is more difficult. So with OMIDRIA on board, I feel like every case does the same. I think of it as a drug that chemically stimulates the iris to keep it at 6 millimeters or larger, so I don't have to use a mechanical device to do that. And by keeping it at 6 millimeters or larger, I can be a rock star in the OR. I can do a great job and make sure every patient does exactly the same as the first one that day. I would describe the adverse event profile for OMIDRIA as the same as placebo. That's what the FDA study showed, and I really have not experienced any adverse events using the drug. Initially I was worried about maybe the ketorolac could be toxic to the cornea, or phenylephrine might cause blood pressure problems, but I haven't seen that at all.